Please describe bendamustine's unique mechanism of action. How does this compare to that of other alkylators?
So bendamustine is a so-called old compound which was developed more than 50 years ago in Germany. And when you look to the chemical structure of that compound, it appears as another alkylating agent because it has this one nitrogen mustard group. However, there's also a benzimidazole ring inside the chemical structure, which is also present in the purine analogs fludarabine and cladribine. So therefore it is a mixture, a hybrid or a class of its own. It's not a typical alkylating agent and it's not a purine analog. Today one is thinking about that bendamustine is more working like another alkylating agent from the way of action. However, it is not very well investigated if that assumption is true. But we see from our in vitro investigations and from cell lines that bendamustine is active in cell lines which are refractory to other alkylating agents. So there must be something unique about this compound, and this is probably due to that very special chemical structure.
Please discuss the infusion rate and the administration of bendamustine. Why is the infusion rate of bendamustine so important?
Yes, that's a very important question because it's absolutely underestimated to follow the guidelines and the recommendation. It is recommended to infuse it within 30 minutes or maybe within 60 minutes, and that's very important because really you need that high peak concentration in the very early beginning of that infusion, and bendamustine has a very short half-life, so half-time, so that is indeed a very important thing to know. And in contrast to that is, in my opinion, that the information for the product is described to make a short infusion but to use 500 milliliter fluid, and that is, from my view as a practitioner, not a very logical approach because 500 milliliter is much too much fluid to get infused in within 30 minutes. So the most important thing is to have the infusion done within 30 or at least only 60 minutes, and that is very important. So it is really a very critical thing not to have an infusion time for approximately 2 or 3 hours, as some already have done it.
It has been shown that bendamustine causes some skin and hematologic toxicities. How do you manage these?
So hematological toxicity is the most well-known toxicity of bendamustine. So it is similar to other alkylating agents. It has as a main toxicity hematological toxicity. However, it was shown that the hematological toxicity was by far lower than, for example, compared to CHOP plus Rituximab. So it does have some hematological toxicity, but it is manageable, and you really do not need growth factor as usual with other cytostatic combinations. And skin toxicity was observed sometimes. I cannot tell you exactly the percentage of patients in which it's seen. I would guess it's approximately between 5 and 7 or 5 and 10%. So occasionally you see some skin rash and some allergic reaction to the skin. So by chance I learned from some colleagues who told me they have never seen any skin toxicity, and it came out that they routinely are giving prednisone in addition to the chemotherapy, maybe because they want to have more anti-emetic drugs given to the patients. And in these circumstances, the doctors told me they have never seen any skin toxicity. In my own practice, I see skin toxicity maybe in 2 or 3%, not more, and it was not a dose-limiting toxicity in my hands. I am, of course, aware from the red hand letter from the FDA in which it was reported that some Stevens-Johnson syndrome appeared, but this was only seen in 3 patients in the United States, and in all 3 patients concomitantly allopurinol and antibiotics were given. So in my opinion, it is very unclear if really bendamustine is inducing such a severe skin toxicity. I have not seen it in my studies, in my own clinical practice, and also it is not reported in Germany throughout the colleagueship.
What are your recommendations for the use of bendamustine in patients with renal impairment?
That's a very attractive side of bendamustine because you don't need to have any caution in patients with renal insufficiency. We give it also in patients with multiple myeloma under dialysis, and you can give it easily in patients with a very low creatinine clearance, less than 10 milliliter per minute, for example. It's possible. This is routinely done in Germany, and also the German prescription guidelines does not limit bendamustine in patients with a renal insufficiency. In the American registration and the label, there it is said that below 40 milliliter per minute you have to have caution, but this is only due to a lack of data. So the FDA was not very confident to recommend it in a patient with a renal impairment because there was no data presented. But out of our experience in Germany, it is a preferred drug to be given in patients with renal insufficiency.
What is the rate of secondary malignancies with the use of bendamustine?
So that question is very important because when you consider that bendamustine is something like an alkylating agent, one would assume that there is a secondary malignancy rate, and of course you see some secondary malignancies after treatment with bendamustine rituximab. But in order to really have a good estimation in which percentage this is going to happen, you need comparison. So I can tell you about the results in my randomized trial. Under my guidance, there was done a randomized trial in first-line treatment, BR versus CHOP-R, and then in relapse disease situation, BR versus fludarabine rituximab. And in both studies, it came out that bendamustine has no increased risk of secondary malignancies. So the numbers are that we have observed 20 patients having a secondary malignancies after a 4-year follow-up, compared to 23 patients who had a secondary malignancy after CHOP-R. So it is more or less the same. At least so far, it is not an increased risk which can be documented with the usage of bendamustine plus rituximab. If bendamustine rituximab is really inducing a higher risk of, for example, MDS, myelodysplastic syndromes, we only can see if we have larger numbers and a longer follow-up. But so far, there is no increased risk.
Other than for the treatment of CLL and indolent NHL, where else do you see a role for bendamustine?
So we think that it is a very good treatment option for patients with a relapsed disease of a diffuse large B-cell lymphoma when they are older and cannot be treated with a high-dose treatment and autologous stem cell transplantation. So usually if patients are relapsing after a CHOP-R regimen with a diffuse large B-cell lymphoma, you would recommend a high-dose treatment with an autologous stem cell transplantation. But in elderly patients, for example, 70-year-old man with some comorbidities, you cannot go for high-dose treatment and stem cell transplantation. And in that special circumstance, I think bendamustine rituximab is a very good treatment option and is very effective. This was shown so far in a controlled study by the Japanese colleagues. They have done a study in that special treatment situation, and they reported a response rate of about 70%. I'm not quite sure about the exact number, but they showed quite considerable efficacy. And in Germany, unfortunately, we don't have a study available for that situation, so I cannot report any detailed results. But from the German practice, we all give in that situation preferably a bendamustine-containing regimen if patients have a relapsed disease with a diffuse large B-cell lymphoma and are too old for a high-dose treatment approach.
What are the advantages of bendamustine as a treatment for CLL specifically?
So FCR, of course, has the highest evidence, but if patients are not fit enough for FCR, and that is a matter of debate what that does mean, but in that circumstance, if patients are not fit enough, then bendamustine rituximab is, of course, a very good treatment option for first-line and relapse disease. So because it appears that bendamustine rituximab has such a high efficacy in lymphoproliferative diseases, the German CLL study group has done a study, a randomized comparison between FCR and BR. This study has recruited enough patients and is closed, and we will wait for the results. But the objective of this trial was to show that BR would be as equal effective as FCR, but to show low toxicity or less toxicity than FCR. So that is a good alternative to the FCR regimen in patients with CLL. Interestingly, in Germany, there is a registry for lymphoproliferative diseases, and by the private practitioners and the community-based hospitals, it was documented that BR is the preferred first-line treatment compared to FCR in that office-based hematologist. That was a surprise because in Germany, as you know, the German CLL study group is a very active study group, and they define the treatment standards for that disease. And in contrast to that recommendation that you should, of course, use FCR as a first-line treatment, the majority of the practitioners in Germany are using BR, despite the fact that the data and the evidence is not as good as for FCR. But as you know, maybe from the history of that compound, the German physicians have a lot of experience with bendamustine rituximab, so that is the reason why they are very confident in the efficacy of BR also in CLL patients.
What dose of bendamustine do you recommend using in CLL in both the frontline and in the relapse settings? And do you tend to use bendamustine with rituximab?
So, of course, I am using bendamustine in combination with rituximab. I think that makes the difference. Bendamustine by itself is also effective. It was shown to be very effective in rituximab refractory patient population with indolent lymphoma, and therefore it has achieved the registration. That is the official label to use bendamustine in rituximab refractory patient population. However, in my opinion, and in opinion of many colleagues in the world, the real value of bendamustine is prior to that, before a patient becomes rituximab refractory. So we have investigated the combination bendamustine rituximab in first line and in second line treatment, and I think that is the most valuable situation for patients to be treated with that combination. And if you are using bendamustine with rituximab, the recommended dose is 90 milligram per meter square on 2 consecutive days, and that is lower than the official label. The official label is describing 120 milligram per meter square repeated every 3 weeks in rituximab refractory patients, and my belief and my opinion to that is that this dose is too high. Also, when you look to the original publication by Brett Karl and Jonathan Friedberg, both have published their results in rituximab refractory patients in the Journal of Clinical Oncology. There it is absolutely clear written that a large majority of patients have to have a reduced dose and cannot continue on 120 milligram per meter square. So in my opinion, that dose is too high, and throughout the world, as far as I know, all colleagues are following our recommendation, which is 90 milligram per meter square when you combine it with rituximab. So the dose recommendation is very easy, 90 milligram per meter square on 2 consecutive days when you combine bendamustine with an anti-CD20 antibody, which is of course in most circumstances the rituximab.
And is that dose that you use the same in the relapse setting, or what dose would you use frontline versus relapsed?
Yes, so we are always using 90 milligram per meter square because this compound in that dose is not too hematotoxic. The only caution you should have is in patient with a CLL pre-treated with fludarabine containing regimen. There we recommend, and that is due to our experience, a lower dose in the relapse disease situation. Then we start with 70 milligram per meter square. So only in relapsed CLL disease, when patients have been previously treated with fludarabine, then we recommend a dose of 70 milligram per meter square. And the routine in Germany is like that. If the patient is tolerating in the first cycle 70 milligram per meter square very easily and has no hematotoxicity, then we are going to increase in the consecutive cycles up to 90 milligram per meter square, also in the relapsed disease of CLL patients.
In which patients with CLL and what percentage of patients do you use bendamustine?
So that is a question I can answer both ways. If you ask me personally what I'm doing in my practice, I have a huge experience with bendamustine rituximab. So I, in my practice and in my clinic, always prefer bendamustine rituximab in first-line CLL and first-line indolent lymphomas. In particular, in patients with CLL pre-treated with fludarabine, of course, the best recommendation in my clinic would be BR. On the other side, when I just pay attention to the literature and the evidence, of course, I cannot give that recommendation in general. This has to be in accordance to the own experience of the colleagues. But when you just follow the evidence in the literature, in frontline, I would recommend FCR in CLL patients. However, in indolent non-Hodgkin's lymphoma, I am absolutely confident that bendamustine rituximab is by far the best recommendation and should be preferred over CHOP plus rituximab.
And would you use bendamustine in the elderly or less fit patients? And when would you choose not to use bendamustine?
So there is hardly any reason to think about that you could not use bendamustine. It can always happen that a patient is not tolerating it. Then you have that experience after the first cycle. It can happen with every compound, with every medication. But before you have used it, there's no reason to not to try bendamustine in case of the patient needs a treatment like that. And I hardly can think about patients who could maybe not tolerate bendamustine. You can give bendamustine in very elderly patients and frail patients. Just think about the other possibilities. If I would think about to treat these patients with chlorambucil, then you need a lot of tablets, which is a little bit complicated sometimes in Germany because you only have these 2 milligram tablets of chlorambucil. So in the end, patients have to swallow more than 10 or 15 or sometimes 20 tablets. And as a doctor, I'm never trusting that the patient has 100% compliance with that oral medication. So it is, in my hands, an easy treatment situation just to give 2 infusions, short infusions with bendamustine, and there is no reason to think that an elderly patient could not tolerate bendamustine. In the end, some patients are not tolerating it after the first or second cycle. They have very severe hematotoxicity. They have some skin reaction or something else. But this is what you learn only after you have tried to use bendamustine in that situation.
What are the advantages of bendamustine as a treatment for indolent NHL and in mantle cell lymphoma?
So the advantage is that you could avoid an anthracycline-containing regimen, at least in these countries who believe that a CHOP-based regimen is the preferred first-line treatment so far. There are some countries, like in England, like in Canada, in which the colleagues are convinced that CVP plus rituximab is enough and it is effective enough. But in the rest of the world, in most countries, CHOP plus rituximab was the most often used first-line treatment approach. And in comparison to CHOP, bendamustine rituximab is less toxic and better tolerated by the patients. In particular, patients do not have any hair loss and feeling much better if they are treated with bendamustine rituximab than compared to the side effects of CHOP plus rituximab. Also, the potential side effects of CHOP plus rituximab can be ignored if you are giving bendamustine rituximab, because bendamustine is not having any organ toxicity like the anthracycline would have.
In which patients with indolent NHL and mantle cell lymphoma, and in which percentage of patients do you use bendamustine in your clinical practice?
So in my clinical practice, I prefer in nearly all indolent lymphoma as a first-line treatment bendamustine plus rituximab. I don't see any reason to recommend another treatment approach in this patient population. And in mantle cell lymphoma, in younger patients, I would approach and I would plan a much higher aggressive treatment approach, such as high-dose treatment with high-dose cytarabine followed by a stem cell transplantation. This would be my first-line recommendation, and this is being done in my hospital in the younger patient population with mantle cell lymphoma. However, this aggressive approach is not very meaningful in patients with indolent and follicular lymphoma, also not very meaningful in Waldenström's disease or patients with marginal zone or small lymphocytic lymphoma. So in these typical indolent lymphoma diseases, I recommend and I treat with bendamustine rituximab as a preferred treatment option.
What dose and what regimen of bendamustine do you recommend using in indolent NHL and in mantle cell lymphoma? So far, 90 milligram per meter square is the optimal dose. It has never been tested if a higher dose would be more effective. Some colleagues are thinking about it. If bendamustine rituximab is so effective with a complete response rate in the range of 40% or so, then one should use a higher dose of bendamustine to achieve a higher complete response rate and to see more treatment success. However, I have my doubts if that is really so easy, and this should have been tested in a randomized trial. So far as I know, there is no randomized trial investigating that issue. So far, I would say 90 milligram is the recommended dose. Please briefly describe the results of your study using bendamustine in first-line indolent lymphoma.
So we have conducted a phase 3 trial, and we have randomized 514 patients with different histologies. The vast majority of these 514 patients had follicular lymphoma. This was approximately 50% of that 514 patients, and the rest had mantle cell lymphoma, marginal zone, and Waldenström's disease. We planned to make the statistics for the total patient group, and the idea behind that was that in Germany you would treat all these lymphoma entities with a CHOP rituximab regimen. This was the standard approach some years ago in the year 2000, 2002 when we planned that study. So we initiated that study in the year 2003, where we assumed that CHOP-R would be given in all these diseases as a standard first-line approach. And so we randomized and we compared it to bendamustine rituximab as first-line treatment approach. Interestingly, we planned that trial as a non-inferiority trial to show better toxicity, and in the end it came out that we have seen superiority of bendamustine rituximab over CHOP rituximab. And this difference was quite large and clinically meaningful, because it was not only statistically significant difference with a hazard ratio of 0.58 and a significance level by far beyond 0.0001, and
But the median progression-free survival also was different, clinically meaningful different. The median progression-free survival in an updated analysis nowadays is 69 months after BR compared to 31 months after CHOP-R. I have to remember that includes all histologies included in that study, also follicular, mantle cell, Waldenström, and marginal zone. So when you look for the subgroups and for the follicular lymphoma, only the median progression-free survival after bendamustine rituximab was not yet reached, and the one with CHOP-R in follicular lymphoma was above 40 months, I think 41 months, and this also was statistically significant different in favor of bendamustine rituximab.
What about the safety results of that study?
So bendamustine rituximab was less hematotoxic, less growth factor like G-CSF was administered. 20% of all cycles with CHOP rituximab were treated concomitantly with G-CSF, and only 4% of the treatment cycles after BR had some additional G-CSF. And then, of course, the hair loss was different. Patient with CHOP-R had some hair loss, or some had total alopecia. With BR, you don't experience any hair loss. Then neurotoxicity due to the vincristine in the CHOP regimen was more prominent in the CHOP-R regimen compared to BR. You have seen more stomatitis due to the higher hematotoxicity of CHOP-R. What we have observed a little bit more frequent was skin toxicity in the bendamustine arm, but it was never dose limiting. And then we have seen more infectious complications after CHOP-R compared to BR. So it is a better tolerated regimen. So it was a very unique situation that you have shown one arm in that randomized trial to be not only less toxic but also more effective. That is something on what you wish as a clinician.
As a result of your study and others in Indolent NHL, do physicians in Germany use bendamustine plus rituximab instead of R-CHOP in the first-line setting?
Yes, you can say so. In this registry for lymphoproliferative diseases, it also came out that in indolent lymphoma, bendamustine rituximab is by far the most often used frontline treatment approach. It is different now compared to 10 years ago. 10 years ago, CHOP rituximab was the one and only standard approach. And when we have conducted that trial, already the doctors adopted that. And after we presented first time our results, nowadays in Germany, all German doctors are convinced. Of course, it is a very unique situation in Germany because bendamustine is approved and reimbursed without any problems. It is registered now for more than 20 years after the reunification of the two German parts, and it was developed 50 years ago. So you can say it is more or less a German compound, and the German doctors have a huge experience. So that is a special situation that so many doctors have adopted bendamustine rituximab compared to other countries in the world.
Please describe the results of your phase 3 study using bendamustine in second-line indolent lymphoma.
Yes, we initiated also another study when we started bendamustine rituximab against CHOP rituximab in frontline. We had also some idea in the relapse disease situation. The big discussion was what should be the comparator, what is the preferred relapse disease treatment recommendation, and we discussed it intensively and came out that fludarabine rituximab is probably a recommended comparator for a bendamustine rituximab treatment approach in the relapse disease situation. This was also recommended from our steering committee based on the results published by Myron Chutchman. He first published it in the year 2002 in Seminars of Oncology. Later on, he published it in a full publication in the Journal of Clinical Oncology in the year 2005. And there he recommended fludarabine in combination with rituximab as a very effective salvage treatment. So that was the reason why we selected fludarabine rituximab as a comparator to bendamustine rituximab.
And in your study, fludarabine rituximab was given over a 3-day period. Why did you choose this method of administration, as we have seen some regimens that are given over 5 days, and might this have impacted the results?
Yes, this may have impacted the results. This is one potential criticism for the study, and indeed we used a 3-day regimen of fludarabine. This is based upon the recommendation of Myron Schutzman's publication. He recommended during that study a dose reduction from 5 days to 3 days fludarabine when it was combined with rituximab, because he has seen in the first 10 patients in his publication a very high and unexpected toxicity. So that was his consequence and his recommendation to reduce fludarabine to 3 days instead of 5 days. And we followed that recommendation in our study. Nowadays, of course, we can discuss if this is a good recommendation. However, it was done as that schedule, so we compared it to 3-day fludarabine combined with rituximab.
Please describe the patient population that was used in this study in the relapse setting, and how many patients were treated first line with bendamustine and or rituximab in this study?
So most patients have been pre-treated with a CHOP-based regimen. Most patients had the rituximab prior to that study, and 10% of the patients have been pre-treated with bendamustine or with fludarabine as first-line or second-line treatment. We also allowed patients with 2 prior or 3 prior regimens to be recruited into that study. So a typical relapse disease study in which 1, 2, or 3 prior regimens were allowed.
Based on the results of studies in the relapse setting, how do you see bendamustine being used in these patients?
So it was a surprise that bendamustine rituximab was so more effective than fludarabine rituximab, because we have seen immediately a difference in the response rates. We observed an 82% overall response rate in the bendamustine rituximab arm, which is what you would expect with that regimen in relapse disease situation. However, in the fludarabine rituximab arm, we only documented a 49% overall response rate. So that was really a problem with that regimen, that it was very ineffective for inducing a sufficient response rate. Once patient had a response, the remission duration was very similar to bendamustine rituximab, so that's an interesting part of the result. But due to the very low overall response rate, the progression-free survival was by far inferior from fludarabine rituximab compared to the superiority of bendamustine rituximab. So it was a median progression-free survival of approximately 30 months with BR compared to only 11 months with FR.
Thank you very much.